welcome to meeting number 91 of the House of Commons Standing Committee on Health. Today's meeting is taking place in a hybrid format pursuant to the standing orders. A few reminders for the folks participating on Zoom. Click your microphone icon to activate your mic and mute yourself when you're not speaking. Interpretation for those on Zoom, you have the choice in the bottom of your screen of either Floor, English, or French. And screenshots or taking photos of your screen is not permitted. In accordance with our routine motion, I am informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Pursuant to Standing Order 108, Sub 2, and the motion adopted on May 16th, 2022, the committee is beginning its study of women's health at long last. Before we begin, I would like to welcome the officials who are with us today, and we have quite a number. From the Canadian Institutes of Health Research, Dr. Tammy Clifford, Acting President, and Dr. Angela Queda, Scientific Director, Institute of Gender and Health, participating via video conference. From the Department of Health, Ed Morgan, Director General, Policy Planning and International Affairs Directorate, Cindy Moriarty, Director General, Health Programs and Strategic Initiatives, and Suki Wong, Director General, Mental Health Directorate. From the Public Health Agency of Canada, Annie Comtois, Directrice Exécutive, Centre de Prévention des Maladies Chroniques et de l'Équité en Santé. Shannon Hurley, Associate Director, Center for Mental Health and Wellbeing, and Mark Nefik, Director General, Center for Health Promotion. Thank you all for taking the time to appear. We're now ready for opening statements of 5 minutes or less, and we're going to begin with the Department of Health. Who's doing the speaking for the Department of Health? Ms. Moriarty. Thank you for being with us. I understand you're a little under the weather, and there were some near heroic measures taken to accommodate that. We're glad to see you here. You have the floor for the next 5 minutes.
Thank you very much, Mr. Chair and honourable members, and thank you for the last-minute accommodations. So as you know, you've already introduced me, so I won't say again who I am. That I'm with the Health Programs and Strategic Initiatives Directorate at the Strategic Policy Branch at Health Canada. Nous sommes ici pour discuter de la santé des femmes. Avant de commencer, je tiens
We're here to discuss women's health, but before we begin, I'd like to make it clear that many trans and non-binary people are affected by women's health issues.
Diverse topics, including sexual and reproductive health, intimate partner violence, women's mental health and well-being, women and aging, women-focused health research, as well as issues pertaining to gender-diverse individuals and trans women. In Canada, women's health as a field of care, research, and program implementation has made great strides. For example, the National Women's Health Research Initiative is advancing a coordinated research program to address high-priority areas of women's health. Funding is also flowing on other fronts. Budget 21 committed $7.6 million over 5 years to Stats Canada to develop and implement a national data initiative on sexual and reproductive health. Malgré ces efforts, des lacunes.
Despite these efforts, gaps remain in our understanding of women's health issues. Compared to men, women, transgender, and non-binary people have poorer health outcomes due to flawed diagnoses, minimized symptoms, a heavier burden of specific diseases, and poorly targeted treatments. These problems particularly affects racialized and Aboriginal women and women with disabilities.
Approach with health data and research results stemming from male-only studies and clinical trials. However, this is changing. Today, much more attention is paid to women's health, and a greater general understanding of women's health issues exists than was the case even a decade ago. For example, since 2007, Health Canada has provided approximately $50 million per year to the Canadian Partnership Against Cancer. The partnership convenes and supports the Canadian Breast Cancer Screening Network. It has also worked with the radiology and breast cancer screening communities to develop a pan-Canadian framework for action to address abnormal cell rates in breast cancer screening. The Public Health Agency also provides funding and support to the Canadian Task Force on Preventive Health Care an independent panel of experts that develop robust and evidence-based guidelines on preventive medicine topics such as high blood pressure and certain cancers. The task force is currently undertaking an expedited update of their 2018 breast cancer screening guideline. The recommendations will be based on assessments of available scientific evidence and involve stakeholder input from multiple experts and patients. Toutefois, pour combler l'écart entre les sexes,
However, to close the gender gap in health, more research is required that focuses on health priorities that uniquely and disproportionately or differently affect women. This includes research with trans and non-binary people, as well as better data.
public healthcare system in Canada, supported by so many dedicated nurses and doctors and other health professionals. However, we also recognize the challenges the health system is facing, as noted in this committee's recent report on Canada's health workforce. Toutefois, nous sommes conscients qu'il reste un grand besoin d'aborder.
However, we are aware that there remains a great need to address women's health issues, take initiatives, and play a leadership role in this field.
Work on a number of fronts. Budget 2016 committed $5 million over 5 years to the Heart and Stroke Foundation to support targeted research on women's heart and brain health and to promote collaboration between research institutions across the country. Budget 2019 committed $10 million over 5 years to help address gaps in knowledge about effective prevention, screening, and treatment options for ovarian cancer. At the same time, the government's also supporting a broad range of initiatives and organizations to promote and enhance women's health. C'est pourquoi le budget 2021 a alloué 40.
That's why Budget 2021 allocated $45 million over 3 years to improve access to a full range of sexual and reproductive health support, information, and services for Canadians facing the greatest barriers to access. Budget 2023 renewed the investment to the tune of $36 million over 3 years additionally.
Organizations are empowered to design and deliver programs to address the diverse health needs of women. De nombreux progrès ont été réalisés ces dernières.
Much progress has occurred on women's health in the last years. Behaviors are changing, and our approach to research, policy delivery, and policy analysis is transforming and continuing to transform.
Sex and gender-based analysis to all of its activities to ensure that the issues experienced by women and gender-diverse individuals are considered when we're developing new policies and programs. This enables us to formulate responsive and inclusive health initiatives to promote greater equity. D'une manière plus générale, la prise de...
More generally, awareness of the importance of women's health issues continues to grow, offering us many opportunities to fill the gaps mentioned above and address gender inequalities between the sexes in healthcare.
Is one more contribution to this important conversation, and we look forward to today's discussions and answering your questions. Thank you.
Thank you, Ms. Moriarty. Next, from the Canadian Institutes of Health Research, I believe we're going to hear from Dr. Clifford and Dr. Kaida. Is that right? Okay.
That's correct.
You have the
Yes.
floor. Thank you. Welcome.
Great. Thank you so much. À titre de présidente intérimaire des instituts de recherche en santé.
As a director of the research branch of the Canadian Institute of Health and Research, I'm pleased to appear before you today to discuss the important topic, along with my esteemed colleague, Dr. Angela Kaida, Scientific Director of the CAIHR Institute of Gender and Health, with whom I will share my time today.
Canada's Health Research Funding Agency, we at CIHR understand the power of research to improve the health and well-being of all Canadians, including women and girls. We know that sex and gender influence our risk of developing certain diseases, how well we respond to medical treatments, and how often we seek out medical care. Yet, as recently as 2010, fewer than 20% of basic scientists, 25% of health systems researchers, and only a third of clinical and population health researchers in Canada accounted for sex in their studies. This meant that research results often stemmed from male-only studies and clinical trials, limiting our understandings of women's and gender-diverse people's health, which obviously impacted the quality of the care that they received at that time. And it's in this context that over the last decade, CIHR has taken action to promote the integration of sex and gender in research, including offering training modules for CIHR funding applicants and peer reviewers, and requiring researchers to integrate sex and gender into their research design when possible. Thanks to leadership from CIHR, along with federal funding, investments in sex and gender science, today the integration of sex in health research proposals in Canada exceeds 90%, 90%, and gender is addressed in the majority of human research studies. Canada is now recognized as a world leader in sex and gender science, and a review that was published in the journal Science ranks CIHR as the #1 agency in the world for the appropriate integration of sex, gender, and intersectionality in funding policies. In addition, CIHR is driving research in key priority areas of women's health. Et je vais maintenant céder la parole à ma collègue, Dr. Kaida, qui nous parlera plus en détail de ces initiatives.
We'll share my time with Dr. Kaida, please. Thank you.
Merci, Dr. Clifford. Comme mon collègue,
Thank you, Dr. Clifford. As my colleague has noted, CIHR-led policy changes have led to major improvements in the integration of sex and gender in health research.
make CIHR-funded science more rigorous and more inclusive to increase research impact. As the scientific director of CIHR's Institute of Gender and Health, I am committed to advancing research that will further help close the gender health gap. This is why I am thrilled to help deliver on a Budget 2021 investment of $20 million for women's health research. With this important investment, CIHR, in partnership with Women and Gender Equality Canada, and in consultation with researchers, clinicians, communities, and trainees across Canada, is leading the National Women's Health Research Initiative. This initiative is advancing a coordinated research program to address high priority and under-researched areas of women and gender diverse people's health. By embracing a community-engaged approach and committing to the principles of equity, diversity, inclusion, and Indigenous rights, this initiative will support the creation of research evidence to improve women's health care, women's health policies, and practice in Canada. As the first phase of this initiative, in August 2023, the Minister of Health announced an $8.3 million investment to support the creation of 10 women's health hubs. These hubs will focus on mobilizing research evidence in key priority areas of women's health, including sexual and reproductive health, HIV care, the prevention of violence, and equity in health services access, to name a few. For example, the Women's Cardiovascular Health Hub, led by Dr. Carrie-Anne Mullen, Dr. Tyas Coutinho, and their team at the Ottawa Heart Institute Research Corporation, will leverage Canada-wide networks to address cardiovascular disease, which is the leading cause of death and hospitalization among women in Canada. And for the next phase of the initiative, CIHR will invest in a hubs coordinating center, biomedical discovery research, translational research in healthcare diagnostics, therapeutics, and devices, as well as implementation research to remove barriers to accessing healthcare. And this initiative aligns with additional investigator-driven CIHR investments in women's health research, which totaled over $60 million in 2021-22 alone. And as a short example, I'd like to highlight the work of Dr. Gina Ogilvie and her team at the Women's Health Research Institute in British Columbia, who are advancing research on HPV vaccination and cervical cancer screening methods. Dr. Ogilvie's world-class research program is accelerating Canada's efforts to become the first country globally to eliminate cervical cancer. So as you can see, CIHR is committed to advancing research that stands to improve women's health and healthcare. And I deeply look forward to the outcomes of your study and would be pleased to assist your efforts in any way. Merci, thank you.
Thank you, Dr. Kaida. We're going to begin rounds of questions now, starting with the Conservatives for 6 minutes. Ms. Vecchio, please.
Thank you very much, and I really appreciate it. And thank you to all of the people who have come here to provide us testimony today. I want to start with Cindy. And Cindy, I've got your first name here because I didn't get your last name down. But you noted about priorities. And I wanted to find out from you, these list of priorities, are the priorities chosen by the health officials, or is there some sort of consultation done with the people on the ground, such as the physicians and nurse practitioners and the people that are working hand in hand with the patients themselves?
Thank you. Thank you for the question. It's really, if I'm understanding your question properly about priority setting generally, it's very much an iterative process. Very often priorities are determined through, long-standing work, trends that are emerging, issues that are being presented to government or to the department. They could come through, there's a crisis or something happens in the media that draws attention to something. So it's not like a one size fits all. If there's a particular issue that you're interested in, I could maybe drill down a little bit more.
No, that's perfect. I just wanted some information on that specifically. A question specifically, though, and you can answer this one, or perhaps somebody from one of the departments may be able to answer this. When we were looking at the gender-based analysis and looking at things that had come out from the Auditor General, it was indicating that only 40% of budgets and policies had actually gone through the GBA. I was wondering if you could advise me whether or not your department went through a thorough GBA for all of your programs, policies, and budget advancements.
Well, speaking for Health Canada, and I'll let my colleagues from the Public Health and CIHR speak for themselves, but generally speaking, the health portfolio is seen as a lead in sex and gender-based analysis. And I just want to clarify that in health, we, like in the rest of the department, it's GBA. In health, we talk about sex and gender because sex is about the biology and the science as well as the gender. So we have consistently been ahead of the pack. I can assure you that all of our budget proposals, MCs, Treasury Board submissions are 100% vetted and go through a process with sex and gender-based analysis.
Thank you very much. I really appreciate that. Shannon, I want to turn over to you. I'm not sure specifically what department you are. I have Center for Mental Health and Well-Being. Is that what I understand?
Yes, that's right.
Excellent. So being a woman and what we're hearing from the numbers, we know that violence against women has just boomed. We know that. And also working on the Status of Women Committee, we know that the money has also increased, but is not keeping up with the numbers of violence. I think 79% is something I've heard most recently. What is it that you see through Health Canada that we are able to do, something that would help start alleviating these issues when we have violence against women?
Right. Yes, thank you. And just to clarify, I work with the Public Health Agency of Canada, Centre for Mental Health and Wellbeing, and I can say that at Public Health Agency of Canada, we really try to contribute to addressing the problem of violence against women, gender-based violence in all its forms, through programs that deliver interventions and also test and learn about effective approaches. So they're building the evidence base of what works.
I really appreciate that. One of the greatest challenges, I think, though, in Canada is the geography, right? If you're living where I live, I'm 20 minutes away from the London Health Sciences Centre, but people that I'm speaking to, especially women who are trying to flee violence, sometimes it's an airplane away. Sometimes there's not a registered nurse on a reserve. How do we make sure that a GBA plus and that accessibility is there for those people who are living remotely?
That's, a really great consideration. And I'll say that the kinds of programs that we support are about promoting the health of people who have experienced violence and also preventing violence through health promotion, healthy relationships, building skills, building ability. So we're not the order of governments that's delivering the services, but we certainly work with partners. It really requires a multi-sectoral approach to address this issue.
And finally, do you have any programs specifically directed at men? One of the things that when we talk about violence against women, we know that it's not just about women, it's about men and women working together to change that type of relationship so that it is much more respectful. What programs do you have that are directed at men and abuse?
Absolutely. It's not up to women to end violence against women. So our programs, we have streams of funding addressing family violence and gender-based violence, and of course these are intersecting issues, and some of the projects funded through those programs are indeed reaching men and boys. There's one, for example, working with police services to look at gender norms. There's one that's working with adolescent boys to teach them more healthy ways of being a guy, expressing their emotions, being able to use language about their emotions. So indeed, we absolutely recognize the need to work with men and boys too.
Awesome. Since I still have the floor, I'm going to pass to you, Mark, because I see that you deal with the correctional system. When we're looking at women in the correctional system, what are the percentage of when we're looking at Indigenous women in the federal correctional systems? Can you give me a percentage there?
Yeah, so I do work for the Public Health Agency. I have worked for Correctional Services Canada in the past, but I don't have a response to that in my current role, so my apologies, but I can look and bring that back.
Wonderful, because I think knowing that correlation is really, really important there as well. But you do bring lots of experience, of course, from that. Would you be able to put on that hat from before and tell me that when we are when we're looking into these penitentiaries, are they actually talking about violence against women, how to change their beings, anything like that? Do you see any of that where we're doing things to contribute to the person's outcomes?
Sure, I'll preface my response with it's been 3.5 years since I've worked for Correctional Services Canada, but I can tell you that you're absolutely right. Women, Indigenous women, are very much overrepresented in the federal correctional system, and there are violence prevention programs that they do offer. I can't give you the details at this point in time. No problem.
Thank you, Ms. Vecchio. Next, Ms. Atwin online for 6 minutes.
Thank you very much, Mr. Chair. And thank you to our witnesses for being with us today for this really important study. I'm really excited for this. I think it's been a long time coming. I'm speaking to you all from Fredericton, New Brunswick, so unceded Wolastoqiyik territory here. And, I think I'll start with Ms. Moriarty. You mentioned specifically sexual and reproductive health, and I have a particular preoccupation with that. I'm from New Brunswick. We are perhaps infamously known for not upholding the Canada Health Act as far as having access, regardless of where you live in the province, to reproductive, access and care. So we actually have a research study that's being undertaken here. It should be close to completion, actually, as far as quantifying what that experience looks like here in New Brunswick and some of the impacts from not having that ease of access. The province was concerned we weren't moving beyond kind of anecdotal evidence. So it was really important to have this research project really capture that. As a result of some of this, we've had actually health transfer dollars held back from the province of New Brunswick. It seems to be the only kind of stick that we have, but it's not necessarily working, especially in a province that has surplus budgets. And so I'm just wondering, can you provide us with any direction as far as the Government of Canada is, what other mechanisms do we have or should we have to enforce the Canada Health Act when it comes to reproductive care and access?
Okay. Thank you for the question. I am not an expert with the Canada Health Act, but I hear you. There have been deductions to New Brunswick. I guess depending on your point of view, whether or not they're significant or not, but in 2020 there was like $334,000. So that may not be having the impact you desire. I think there are limits to the Canada Health Act. I think what I would point to is other efforts that the government is making through the Sexual Reproductive Health Program. We are funding community-based organizations. We have some funding that's specifically targeted to improving and increasing access to abortion, we can't pay for the abortion services itself. That would be that's within provincial jurisdiction, but certainly everything that helps the women get there and get back. So travel, childcare, hotels, so this is particularly an issue with geographic boundaries, women of low income, and all sorts of other circumstances. And so that's where we're putting our efforts, is into improving and increasing the access overall.
Thank you. Clinic 554, it's here in Fredericton. It was often kind of at the center of that conversation, but what it also served as really was almost a center of excellence for trans care, for gender affirming care. Fredericton is the latest census data has us as the 4th most gender diverse city per capita, which we're very proud of. But again, we know there's issues with access. So again, just seeking your advice on how we can ensure better health outcomes for the 2ish LGBTQ plus community, again, regardless of jurisdiction, even in small provinces like New Brunswick.
Thank you. That's a big question. We're very well aware of the misinformation and disinformation campaigns, the public discourse that's anti-trans, anti-2S LGBTQ2. So a lot of the sorry, I'm just having COVID brain fog. A lot of the context is just, it's really around the social context and where people are at. So it's a challenge that I think every jurisdiction, every community is going to have to sort of, meet with different things. We are providing funding through the Sexual Reproductive Health Program to support access, training for healthcare providers, support going to patient-centered organizations in terms of knowing your rights, knowing where to go. Very concerned about ensuring that people know where to get good information and reliable information, and that they're taken care of safely. But I think there are large challenges ahead of us. I don't want to deny that on this front, and it's something that we're looking at with great concern.
Thank you, and I hope you feel better soon. So I've got another big question, and I know my time will be wrapping up, but it's for Dr. Kaida, and this will be a recurring theme for me. I'll ask it just about every time we have witnesses on this panel, and it's regards to Joyce's principle. So I'm thinking about the horrific story and experience of Joyce Echaquan in Quebec around systemic discrimination and racism in our health system. So I'm really looking for ways that we can kind of formulate measurables, or what can we do in a healthcare setting to ensure that everyone has access, regardless of where they come from, and to ensure that they're being culturally respected at the same time.
Yeah. Thank you so much for that excellent question. I will just share with you that I do hope to be asked those questions over and over. It's similarly a priority for me. From a research perspective, certainly CIHR recognizes racism, discrimination as structural forms of discrimination that negatively influence our health. We also recognize that forms of racism and other forms of discrimination disproportionately affect key members of our Canadian communities, including Indigenous women, Black women, and other racialized communities. And so in terms of our priorities, we have been funding research teams that are looking specifically at not just the impacts of racism on health outcomes, but as well as trying to identify community-led solutions for how to address racism in the healthcare system, as well as generally in our society as Canadians. And so I think that focus on a specific question of racism, not just generally about structural violence, but specifically about racism, is such an important part of what we are committed to in terms of the research that we fund on health outcomes.
Thank you, Ms. Atwin. That's your time. Suite, Madame Larouche, pour 6 minutes, s'il vous plaît.
6 minutes, Madame Larouche. Thank you, Chair, and thank you to all the witnesses for their update on this very important study. It's very important to realize how much work there's yet to do. In your comments, you've all mentioned we're not yet focused enough on how to provide these services and this access to services to women and non-binary people. In one of your answers, you talked of the cervical cancer, Dr. Kaida. Cervical cancer, of course, is on the rise. And what would you propose by way of approach to this situation?
Merci pour la question.
Thank you for the question.
Cervical cancer is a priority for us as Canadians, and is a priority for us at CIHR in terms of innovative research to address rising incidence of cervical cancer. As I mentioned earlier, we are really proud and fortunate to be able to fund Dr. Gina Ogilvie at the Women's Health Research Institute here in British Columbia, whose work has focused for decades on looking at HPV vaccination, uptake of HPV vaccine, and moving us from cervical cancer screening towards HPV screening as a strategy towards eliminating cervical cancer in Canada. And so we also, the Canadian Partnership Against Cancer, or CPAC, is funded by the Government of Canada and its partners, who have developed an action plan to eliminate cervical cancer in Canada. And importantly, I think this action plan engages with partners across the country, and these partners include women and gender diverse people with lived and living experience of cervical cancer in its priorities. And just to reinforce that the priorities include the improvement of HPV vaccination rates among young girls and young boys, as well as young women, implementing HPV primary screening and enhanced efforts to follow up of abnormal results of testing procedures. And so CPAC also hosts the Pan-Canadian Cervical Cancer Screening Network, which undertakes system performance for reporting on cervical cancer and supports the development of sharing best practices for screening and treatment. So to reinforce that this is a priority area for research and programming and practice to transform cervical cancer incidence and impact for women and gender diverse people in Canada. Thank you.
Parfait. Donc, je comprends.
Thank you. So it's a combination of vaccination and perhaps early discovery of through screening to try to prevent cervical cancer. In fact, it's the only form of cancer for which there is a potential vaccine, the HPV vaccine. I'd like to continue with Ms. Moriarty. You've also mentioned in your preliminary remarks that research hubs in Canada where sex and gender, certain populations are prone to specific diseases. It's one of the 12 determinants of health, of course. You've named quite a few things. An approach which was more focused, a little more defined. I'd like to have a few more examples, if you will, of factors related to the health of women comparative to the health of men. Thank you for this question. Well, I think I understood your question, but no, well, you talk of different diagnoses of treatment, of symptoms that were not quite identical between men and women, or these separate populations, if you will. I didn't mean to interrupt and overspeak. Well, as a general statement, it depends on the circumstances and conditions. If someone is cardiac disposed, if you will, most of the diagnostic approaches are for men. And women do not manifest the same symptoms when they have a heart attack. Another example, I might refer to my colleague Edward, but historically, many pharmaceuticals have a dosage size for the mass of a man, generally speaking, and it's too strong for women. As to symptomology, it's quite difficult to identify one specific health condition that isn't involved. And this is why we are doing a gender-based analysis for all sexes and genders, because the needs are very, very different for each sub-population.
For men and women, just in terms of differences.
No, do you know what? I think you did it wonderfully. I'd only add that we do have a expert scientific committee helping to provide the department with advice on these issues as well.
Thank you.
Other than that, I think you covered it well.
Thank you, Mr. Morgan. Merci, Madame Larouche. And next, Mr. Garrison, please, for 6 minutes.
Thank you very much, Mr. Chair. And I know you all note my late arrival here this morning. The vagaries of House scheduling meant that Ms. Idlout had to step into the House to give a speech on the very important Truth and Reconciliation Call to Action number 6 on physical punishment of children. So I get the privilege of being here for a few moments on this very, very important topic. And I know other members of the committee have already noted that this is a long overdue study in this committee. And one of the things I hope as the committee works its way through that it will consider including in its mandate here in Study of Women's Health is the study of gender-affirming healthcare for transgender and gender-diverse women in this country who do not have equal access to services. But I want to focus my questions this morning on something that most frequently comes up in my riding when it comes to women's health, and that's access to mental health services, especially for young women and girls in Canada. And also because my riding stretches out from urban to rural in rural areas and this lack of availability. So I know we had the House of Commons Status Movement Committee in March earlier this year completed a study on the mental health of young women and girls. And so I guess my question is to you, Ms. Wong, is how the government is making progress in responding to those recommendations, making sure equitable services are available in mental health for women and girls.
Thank you for that question. And I think as members of this committee know that the delivery of health services and access is the responsibility of provinces and territories. So with that view, we work very closely with our colleagues in the provinces and territories to ensure that that the access to vital mental health services are provided in a timely way. And as you know, that just represented by the sheer number of colleagues around this table, that the delivery of mental health services is shared across of the federal jurisdictions, whether it's a public health agency from a prevention and promotion perspective, from a research perspective, my colleagues at the CIHR, as well as our colleagues at the Women and Wage, right, Women and Gender Equity departments as well. So working very closely with our partners in other federal governments and departments. As you know, also recently in our budget, in the recent budget, the amount of $25 billion over 5 years was transferred to PTs to ensure that provinces and territories do address mental health as part of the shared priorities. So working very closely with colleagues to ensure that the really important recommendations from the committee continue to be addressed.
Thank you very much. I appreciate, of course, that health and mental health is a shared jurisdiction, but there are some areas in which the federal government has primary jurisdiction, in particular in dealing with mental health for Indigenous people. And I have a large Indigenous population in my riding, both on reserve and an urban Aboriginal population. Can you say a bit about what's happening with the provision of mental health services for Indigenous communities, making sure that culturally appropriate services are available?
Absolutely. Just want to say that the best people to answer this question would be our colleagues at Indigenous Services Canada. However, with respect to how we are working with to increase access to mental health services in Indigenous communities, we're working very closely with our colleagues. There are specific hubs, especially for access for youth, right? Youth for children in the as part of our integrated youth services program at the federal level. So working very closely to advance and roll out those services in the communities as well.
Again, I want to go back to, I know delivery is primarily a provincial responsibility, but we see very large gaps in the availability of mental health services in rural areas throughout British Columbia, where I'm from. And quite often people in crisis are told to come back later because of a long wait list for services. So are there any ways in which the federal government can provide, say, pilot projects in rural areas or leadership in rural areas to improve the access to services, perhaps through technology?
Right. So one of the programs I think it's important to actually address in terms of access, and especially rural access, is the Wellness Together Canada program. It was first implemented during the pandemic to assist Canadians from all jurisdictions to have access to 24/7 counseling, and also as well as to access their own mental health services. So right now, from a delivery of mental health services virtually, we would like to point to the Wellness Together Canada portal, where all Canadians can have 24/7 access to not only for self-assessment, peer counseling, but also from a 24/7 mild to moderate access to mental health services.
Thank you.
30 seconds, Mr. Garrison.
I'll just ask a quick question about access to reproductive health. And I'm not sure who this actually goes to around the table. British Columbia recently made reproductive health and birth control free. Are there any initiatives by the federal government to encourage other provinces to make contraception widely available, especially to young women who don't have financial resources?
Thank you for that question. That would be for me. I'm not specifically aware of discussions between the federal government and provincial jurisdictions on that matter. I would expect that other jurisdictions are looking at that closely. I was certainly very happy to see that initiative from BC.
Thank you, Mr. Garrison. Ms. Moriarty. Next, Ms. Roberts, please, for 5 minutes.
Yeah. Okay. Thank you, Mr. Chair. So my question is one of general, so I'm not sure who wants to answer it. So I know in our province of Ontario, I've met with numerous international doctors that have passed their boards and unfortunately can't practice. And I know from speaking to residents that there is a lack of services. What, if any, and I'm not sure who wants to take this question, what solutions or issues do you hear, and how can we improve that? Because I don't think it's just an Ontario issue. I think it's across Canada. Can someone maybe respond to that?
Thank you for the question. I don't believe there's anyone on the panel that has the specific knowledge for that question. We can take it back. I can tell you that in some of the other issues that those of us are representing, where our focus is really working with providers to improve their capacity and knowledge to deliver services properly, but it's not focused on recruiting other healthcare workers or looking at foreign credentialed workers. I believe the committee recently did a study on health human resources, and there should be a separate response on that. But we can take that back if that would be helpful.
So one of the reasons I'm asking that question is because I recently met with a constituent who was very upset about the fact that she had to wait so long to get a mammogram because of the waits and the whole timelines and trying to get an appointment with a doctor that specializes in her particular cancer that she was waiting for. And by the time she did get in to see the doctor, the cancer had progressed to a stage 3. So how can we protect women if we don't have the capacity to service them is my concern. I don't know who wants to take that.
Enough doctors, right?
Thank you for that. I don't. It's hard. I can't see my colleagues in the room. If anyone's putting their hand up to answer, I'll step back. But I think that's something we have to take back. And I think I just want to recognize that these are challenges not just for women, but for everyone in the healthcare system. I think we're all aware of some of those anecdotes in our own lives among our friends. And it's a bigger challenge in terms of health human resources. There are efforts underway. The federal government is working with provinces and territories looking at initiatives and different efforts, but I just don't have the depth of knowledge to speak on those with any authority.
So if we look at Canada as a whole, is there one province that would be an example to the entire country that does provide services on a much more efficient manner, which could be adapted to other provinces?
I could take that question back. There may be some good examples in one area over another area. Sometimes these examples are more localized. They're not even province-wide. I think that's one of the challenges is the diversity of how healthcare systems are delivered across the country and the various focus on priorities. But there isn't one province in particular that as a whole has got this figured out and sets the example for the others.
So I'd like to ask Dr. Clifford, what is the percentage of women with health issues like cancer, mental health issues, as opposed to gender? So if we look at transgender, what is the percentage? I'm just trying to understand where we need to focus, if you could help me understand that.
Sure. Thank you so much for that question. And I wish I had the number right on the tip of my tongue or at the front of my head, but I'm happy to bring that number back to you. It's a critically important question, and I'm so glad that you brought it forward here today. We'll get that information for you.
Okay, thank you. Do I still have?
Just under a minute.
Okay. So my next question would be about, we've had a lot of, I heard from Cindy that there's been a lot of funds provided through Health Canada on different research products. Which one was the most successful as far as research? Have we come up with anything? For example, I know we keep praying for a cure for cancer and heart disease. Is there any area of research that we've really excelled in?
I think I would turn to my colleagues at CIHR, and then I also wonder, Annie, if you want to speak to the breast cancer screening guideline work.
Thank you.
To kind of to throw the ball over to my colleague, Dr. Kaida, but I know that this is right in your area of research, so over to you, Angela.
Yeah. Thank you so much for that question and for an opportunity to share success stories as well. And I do think that we have a really robust women's health research community here in Canada. And we have, I would say, a few really shining examples of research informing practice that leads to health outcomes. The examples around HPV vaccination, HPV screening, the examples around sexual dysfunction, sexual pain, and how that research is implemented to transform health outcomes for women. We also have really successful examples of women-centered HIV care and the provision of care services for women living with HIV, women and gender diverse people living with HIV, which I would estimate that with as recently as 10 years ago, we really did not have a robust evidence base that could inform clinical practice. So there are many other examples, but I want to assure you that we have some really shining success stories of women's health research in Canada that is being implemented to lead to tangible changes in women's health and women's health care.
Thank you, Dr. Kaida. Next, we're going to go to Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair, and thank you all the witnesses for being with us, and thank you the hard work you're doing. My first question is to Cindy Moriarty. According to Dr. Bruce Alward, a Canadian physician and epidemiologist and Assistant Director General of the WHO, he said pregnant women, babies, and children face some of the gravest consequences of all forms of impact of climate change, such as heat and air pollution. Do you all agree with this statement? But my question is, what research and work has been done through the health portfolios on the impact of climate change on women's health?
Thank you for the question. I'm not familiar with that work by the WHO. It doesn't surprise me. Pregnant women and kids and babies are more vulnerable generally to a number of conditions. This is fairly new work in terms of looking at the impact of climate change. It's something that the department is looking at now in terms of just like we look at sex and gender-based analysis, considering the impact of climate change as we're developing programs and policies. But it's relatively recent. So I don't have an exact, like we've been doing sex and gender-based analysis for years, so we can point to sort of past work that has reached some result. I don't have a specific example for you with respect to climate change. I don't know if any of my colleagues around the table would be better positioned to answer that.
And Dr. Kaida, you want to add on that, please?
Yeah, thank you so much for that question. It's such an important question. I am aware of that report. So I will just share that from a CIHR perspective, absolutely, the gender dimensions of the impacts of climate change are are a priority for us. I can speak to a few recent funding opportunities that CIHR has held to support research in this area by our research community, including a funding opportunity that was actually a response to the Chief Public Health Officer of Canada's report on mobilizing public health action on climate change in Canada. And so there was a funding opportunity put forward by several of our institutes that really did ask our research community to address the priorities raised in the Chief Public Health Officer's report around climate change and to integrate the sex and gender-based considerations, of course, within that research. And so that's a fairly new funding opportunity. It was launched in 2022, so we're carefully and eagerly following the work of these researchers to inform our evidence base around how climate change is impacting women, girls, gender, diverse people here in Canada as well as globally.
And, Dr. Kaida, I also want to add on that we know that evacuation in BC and across the Canadian North caused interrupted crucial care that led to stress for pregnant women. Cause serious high blood pressure, or it can also impact on their whole health. What perinatal health measures, we are taking? Are we making any programs for that? And how government is taking measures on that?
So thank you again for that great question. I'm going to comment briefly, and then I'll invite my colleague, Dr. Clifford, or from Health Canada to comment further. So I know that we had funded research around the Fort McMurray fires, documenting what had happened in terms of health outcomes and health consequences of the Fort McMurray fires, as well as the recovery period. I'm not familiar at this time with the specific findings related to perinatal health, but I can certainly look into that and get back to you with some specific responses. But I'll open that up to my colleagues as well in case they have additional information.
I would like to address.
Yes, Dr. Clifford.
Sorry, I didn't mean to take your turn, but I want to speak about what Health Canada is doing in the area of perinatal mental health. We recently funded a study with Women's College, Dr. Simone Vigo, to actually look at conducting a study on perinatal mental health to identify treatments and guidelines, clinical guidelines for practitioners for perinatal, not just from the pregnancy aspect, but postpartum as well. So Dr. Vigo has just started this work. She's talking to stakeholders, people with lived experience, to look at how she can develop culturally safe, evidence-based clinical guidelines.
Thank you, Ms. Wong. Thank you, Ms. Sidhu. Suite, Madame Laroche, pour 2 minutes et demi.
Madame Laroche, 2.5 minutes. Thank you, Chair. Mr. Morgan, you've answered some of the questions I had my first turn. Now, among the various countries that may have had a strategy on women in health, Australia, New Zealand, Scotland, UK, is Canada going to renew its strategy, Women in Health? If so, do you have a timeline for this? And what might you tell us about elements of that strategy? And how would we compare with these other countries? Well, thank you for that question. Currently, we don't have a plan to renew the strategy, Women in Health. One of the major differences between Canada and other countries is the challenge that we have with jurisdictional issues. It's a provincial jurisdiction, of course, for the administration and provision of these services. So there's a limited range of activities that the federal government can undertake. Another observation, I was involved with Health Canada in this strategy in the past. our focus was very, very targeted. It's a separate silo, if you will, and it's not integrated within all of our other health and service policies and services for which we are responsible. With the evolution of health and gender, it's an expectation that every policy, every program, every service will take into consideration women's and diverse sexual identity be taken into consideration. Well, thank you very much. Coming back to Ms. Moriarty, I'll come back to you again, Mr. Morgan, in my next turn. Okay, thank you, Madame Laroche.
2.5 minutes.
Thank you very much, Mr. Chair. I want to return to something that Dr. Kaida raised, and that's the addressing of HIV/AIDS and the possible eradication of HIV/AIDS. So the federal government adopted targets a number of years ago, yet in the last budget there was no new funding, in fact not even a mention of HIV/AIDS in the federal budget. So I'm wondering, I guess, how we're doing on achieving the goals that Canada set for itself in terms of eradicating HIV, and whether we really recognize that those who are suffering from HIV/AIDS now have shifted. As a gay man of a certain age, HIV/AIDS has always been associated with older gay men, but we now see an incidence much more prevalent among women, and in particular Indigenous women. So I wonder how we're doing on those goals we set for ourselves in eradicating HIV/AIDS.
Thank you again for such a great question. So I think that our response in Canada I'm going to really speak from a research lens, and I'll invite my colleagues to speak from a policy and service delivery lens. From a research perspective, I think we obviously have seen a completely transformation in what HIV/AIDS looks like for people living in Canada over the last 30 to 40 years. And just the research base, the scientific contribution to that change has been, I would say, nothing short of remarkable. I think I absolutely agree with you. I think in HIV, we do see desperate disparities in terms of what it means to be a person living with HIV today or a person at risk of acquiring HIV today. So certainly we've seen some remarkable progress for gay men, particularly those in urban settings, whereas we have seen much less progress and some really concerning trends for women, transgender individuals, especially those in the prairie provinces of Saskatchewan and Manitoba. So in terms of meeting our targets, we certainly have not we have not met those targets uniformly. We have some communities and populations across Canada who have exceeded the targets set by the federal government and by community organizations themselves. But certainly we do continue to see gender-related gaps in terms of achieving those targets. I'm very happy to say that one of the National Women's Health Research Initiative hubs that were funded earlier this year is focused specifically on improving access to care, treatment, prevention services for women and gender diverse people living with and affected by HIV. And so now mobilizing that research evidence base, we are very hopeful, I think, to see that will help minimize the gaps that we are currently seeing today.
Thank you, Dr. Kaida. Next, Dr. Ellis, please, for 5 minutes.
Well, thanks very much, Chair. Thanks, everyone, for coming. Ms. Moriarty, in your opening statement, you talked about high priorities of women's health. Could you enlighten the committee as to what those are?
Thank you for the question. I mentioned a number in my opening statement, but I think the current priorities first of all, everything is a priority for women's health. All of the issues that we're looking at, we're also looking at with a lens in terms of impact on women. And speaking sort of for the health portfolio, not just for the department, but sexual reproductive health is a key priority. Cancer research, breast cancer screening. We have a scientific advisory committee, as my colleague mentioned, that's looking at medical devices and their impact on women and sort of the drug regulatory. I mean, there's not a health issue that doesn't have an impact on women. It doesn't require that attention.
Yeah, of course there is. That makes perfect sense. I guess the question, as I heard you pose your answer, though, there was high priority areas specifically for women's health, and I was wondering if there are things you did mention ovarian cancer. There was $10 million in funding allotted in 2019. Can you tell us a bit about that? I mean, ovarian cancer, as you, I'm sure you well know, is always detected too late. There's not any great screening programs for it. How are we helping women in Canada really deal with ovarian cancer specifically, and how has that $10 million been spent?
So thank you for the question. I don't have a lot of depth of knowledge in terms of ovarian cancer. I'm not sure if I have anyone at the table today that can help you, but if not, we can take that back and come back to you.
Dr. Clifford wants in here.
Sure. And I probably don't have the, I'm not an expert in this space at all, but I did want to let you know about some research that we have funded through CIHR. About $35 million in funding towards ovarian cancer research in the past 5 years. And this research focuses in on projects that look at point-of-care testing devices. So recognition there around point of care, meaning perhaps increased accessibility for those who are living outside of urban areas, improving detection and diagnosis, and of course treatment. And in particular, there is a large project that is going on at the UBC with Dr. Samuel Aparicio, and it's working on, detection in that space. So again, it's research that's underway. As Dr. Kaida mentioned in her response to an earlier question, we will be paying attention to that research as the results come out in order to implement them into care. Thank you.
Thank you very much. And through you, Chair, if I might ask both of our guests to table that information with the committee, that would be ever so helpful, since ovarian cancer will be one of our areas of focus. Dr. Kaida, you had mentioned specifically there were $8.3 million for women's health hubs. And again, I'm just looking for more specificity around that. Where are the health hubs located, and maybe just a line or two about what they're actually doing?
Thank you so much for that question and for the opportunity for me to share. So we funded 10 national women's health research hubs across the country. We have them distributed. We have 3 that were funded in British Columbia. We have 3 that were funded in Alberta. We have, I think, 2 that are in Quebec, I think 2 that are based in Ontario. But across all of the hubs, one of the key criteria was that they had a national scope, and that involved including researchers, clinicians, people with lived and living experience, Indigenous leaders, trainees, etc., from across the country. So even if a hub was specifically funded in Alberta, for instance, that there was a national network of folks committed to that research area. If I can just share a couple of examples of hubs that we were able to fund.
Actually, Dr. Kaida, we're just short on time. If you wouldn't mind tabling that with the committee, that would be excellent. I'd really appreciate it.
I would be delighted to. I'd be delighted to do so.
Thank you. Sorry for interrupting. Chair, I think I have about 30 seconds left or so. But whoever may have an answer, we often talk about there's multiple screening programs, specifically on cervical cancer, that are great across this country. How do we focus on allowing one of them to come to the forefront, realizing there is provincial and territory supervision of those projects, but sometimes somebody's actually better at it than another? How do we help that happen? Anybody have an answer? Cervical cancer? Okay, thank you.
Okay, thanks. Sorry, we'll come back to you on that.
Dr. Pawlowski, please, for 5 minutes.
Well, I'm surprised Stephen didn't go where I'm going here. Breast cancer screening guidelines. So I thought I would first, I think Ms. Moriarty wanted to talk about this. I think also perhaps Ms. Comtois. As you know, the current recommendations come from the Task Force on Breast Screening and came out in 2018. According to the government website, these are currently being reviewed. That was of June 2023. I wonder where that's at. I think I have certainly heard a lot of concerns about those recommendations, and particularly from the group Dense Breast, which is made up of breast screening experts who feel that the current recommendations are inadequate. Currently, we're not recommending any mammograms for women under 50, and certainly some of the concerns are that Black and Asian women tend to have their peak incidence of breast cancer is 10 years younger than Caucasian women. Also, women who get breast cancer early tend to have more aggressive cancers. The U.S. Preventative Task Force draft recommendations are now that women start getting mammograms at age 40 and every 2 years up until age 76. So again, we're at 50. This is potentially a big problem. If you listen to dense breast, this is resulting in quite a few women not being diagnosed with cancer as early as they should be. It is being reviewed. When will those reviews be finished, and when will we have new recommendations? So I ask either of the two of you, Ms. Moriarty or Ms. Comtois, hopefully someone has an answer.
I think, Annie, that one's for you.
Yes, happy to take it. Thank you very much for your question. So on November 15, the Canadian Task Force on Preventive Healthcare, which is an arm's-length independent organization, announced to their members and to the public that their guidelines had to be delayed to the spring of 2024. They had initially anticipated to release it in the fall, but because of the volume and complexity of the evidence that they are currently looking at, which includes looking at evidence for women with dense breast, looking at health equity consideration, they determined that they needed a little bit more time, and the organization they're working with requested more time to do so. So now they're looking at spring 2024 to release the new guidelines.
Now, I believe the Task Force on Breast Screening is an arm's-length body made up of 15, I think, primary care practitioners. Certainly, according to dense breast, they had some complaints about the decisions of the committee and the fact that the committee did not include people with an expertise on breast cancer or breast cancer imaging. I admit a somewhat biased perception because I talked to dense breast, but I haven't talked to the people on the committee. But certainly there was concern that there ought to be specialists in that group, and I certainly have some sympathy, being my whole life an emergency room doctor or doing other forms of general practice. I always was happy to bring in a specialist who knew more about this than I did. So why do we not put specialists on that group that makes these recommendations? And is there any consideration of perhaps changing the makeup of that group of people?
I would just start with a clarification. So it's the Canadian Task Force on Preventive Healthcare. So they develop a wide range of guidelines, including breast cancer screening guidelines. So it's a subcommittee, a working group of the whole task force that is developing the guidelines. And as part of that working group, they have 4 experts supporting them to do that. One is a clinical oncologist, a surgical oncologist, a radiologist, and a radiation oncologist.
Is that the group that's currently looking at making up new recommendations?
Exactly, yes.
So that's new. You have, in fact, changed the approach then?
My understanding is that there was always experts brought into the development of guidelines. But for this one instance, I know that there's specifically 4 experts that are engaged in the working group, including 3 patients with lived experience.
It wasn't my understanding that there were experts brought in, because that was part of the complaint. Anyhow, okay. So, and who selects the members of the task force? And I assume it's someone in government. Who is that?
So the selection of task force members is done through a selection committee. There's members, the chairs of the task force are part of that selection committee. There's also a representative from the Public Health Agency of Canada, and also one from the College of Physicians. Canadian College of Physicians is also part of the selection committee.
Thank you, Dr. Pawlowski and Ms. Comtois. Next, Dr. Kitchen, please, for 5 minutes.
Thank you, Mr. Chair, and thank you all for being here. It's greatly appreciated. I know we have Department of Health and PHAC and researchers here as well, which it was great to have. One of the things that we're looking at women's health and ultimately how do we address this issue? And there's a lot of concern, and I'm going to go right to what I hear from patients. And ultimately, one of the concerns that you hear from patients is that female patients in particular, can't find female practitioners. Now, when I went to school 39 years ago, there were more men than women in the practice. Now today, when you look at it today, you're looking at over 50%. My latest research I saw, basically in physicians, overall in Canada in 2022 indicated that 49.7% were female. When we look at gynecologists, we see that just under 60% are female gynecologists, which is great to see, and because that knowledge is there, there's that ability to interrelate. But the concern that a lot of patients have, and female patients, is they can't get access. And they can't get a practitioner who will talk to them, or having that female practitioner that they can relate to. And I'm just wondering from all of you, and maybe I'll start with Dr. Clifford, I mean, what do you see that we need to be able to do here in Canada to say, making sure that we have more female practitioners, and B, making certain that we have them out there such that patients have a chance to see them?
Thanks so much for the question, and I really wish I had an answer to it as well. I'm hoping that the other study that occurred on Health Human Resources might shed some light on that, and in fact, if it was taking a GBA plus approach, that should be picked up in that conversation as well. From CIHR's perspective, I can tell you what we do in terms of researchers who identify as female, because we've certainly recognized the importance of this in terms of not only the research community, but the type of questions that researchers get studied. And there is a link there in terms of what actually gets taught to physicians, and of course what gets practiced. And for a few years now at CIHR, what we've decided to do is equalize success rates, if you will, in our largest grant program, which is called the Project Grant Program, because we recognized that despite the fact that there are increasing numbers of female principal investigators who are applying, they were not, for a variety of reasons, achieving the same success rates. So for a few years now, we have said, for example, if 40% of the grants come in from female researchers, 40% of the grants that we award will also go to female researchers. So that is one step. I know it's not specifically answering your question, but in terms of research contributing to clinical care, we felt that this was important to do based on the levers that we have.
Thank you, and I appreciate it. And you've opened a whole new kettle of thought in my mind, but I guess, as you indicated, CIHR gets a lot. There's money that's given by the federal government for a lot of research, and that's great to see that you're looking at delegating that for female researchers to come out. But ultimately, the patient wants to know the outcome, and they want to know the research actually is going to provide an outcome to something that's going to improve female health. And I'm just wondering, how many studies are actually being done where you've actually got an outcome that is being able to be put forward to improve female health care?
Wonderful question, and I might also tee up my colleague to be ready to get in here with specifics. What I can let you know is, and again, it's relatively recently, but CIHR now requires those who are funded through federal tax dollars to ensure that the results of their research end up in the public domain. So this is a fairly new phenomenon. This is particularly true for clinical trials, that those data need to appear in the public domain within 1 year of completion of the study.
Thank you. I know my time is basically up, but I suspect we will probably address it when we get to the endometriosis study. But the reality is that where we have so many issues dealing with endometriosis, and we have especially, I know when I went, I sort of took an interest that I followed my stream into what I wanted to go to, and I see that so much out there. The concern we have for so many patients that are dealing with endometriosis is that they're not able to find a practitioner that even has it as an interest, or to even be able to answer their questions. And I'm wondering how, and perhaps you might be able to provide that for us, of suggestions of how do we get that interest into practitioners such they're aware of this topic and continually on top of it, such that when women come to them, they're able to deal with that aspect. But I realize there's no time to answer that, but I appreciate that. Thank you.
Can you respond very briefly to that? Because I would be interested to hear the response, but although we are out of time. So.
Sure, maybe.
Do you want me to weigh in,
Cindy.
Tammy?
Sure.
Yeah. Thanks. Sorry. So very, very quickly, we are funding a couple of projects through the Sexual Reproductive Health Fund focused on endometriosis. One is going to the National Network of Endometriosis. Sorry if I don't have the name exactly right. They're doing patient-centered public education. And we're also providing funding to the Society of Obstetricians and Gynecologists to look at capacity building and training for healthcare providers to have a better understanding of endometriosis. And happy to provide more information on either of those if that would be helpful.
Thank you very much, Ms. Moriarty. Dr. Hanley, please, for 5 minutes.
Hello to everyone, and thank you so much for coming out. And I also want to thank you for all the work that you do. I have, first of all, I just wanted to briefly clarify. I believe there was a comment earlier from my colleague, Madame LaRouche, about an increase in cervical cancer incidence. And to my knowledge, there is no increase. There may be recently an attenuation of the decrease, but I wonder, Dr. Kaida or someone else, if you could please clarify that quickly for us.
Thank you so much for the question and opportunity to clarify. So I don't have the specific numbers of cervical cancer incidence in Canada right now, but I do know that we, because of improving detection and earlier screening, we may see an increase in the number of cases that are detected, but that's possibly a good sign. It just means that we're identifying those cases earlier. So yeah, unfortunately, I don't have the numbers right in front of me about whether we have seen an increase in cervical cancer in Canada or whether it is, as you say, an attenuation. But I'm happy to provide that.
I think that would be very useful to get some clear, some clear data on that and clarification, because despite what you're saying about increased detection, I don't believe that that's a factor, but I could be wrong if there's a recent change, and that would be very important for us to know. But I wanted to switch to a point that was referred to in just earlier, but just want to get a bit more information. And this is about perinatal mental illness. Recently, I had a conversation with someone in my riding who described her own experience, but also was advocating and researching on how we can improve access to perinatal mental health services for those mothers who are struggling. Whether expectant mothers or after birth or through the process. So, and we know that getting help has not always been easy. Now, Ms. Wong did mention the project, which I appreciate, with the project that is currently underway through, I believe, through Women's College, but I wondered if perhaps Ms. Hurley and also Dr. Kaida, perhaps starting with Dr. Kaida, since you were just on, whether you could briefly comment on what efforts and initiatives in improving access to perinatal mental health services there are from a research point of view, and perhaps I could then ask Ms. Hurley to comment on other projects within the scope of the Public Health Agency.
Great. Thank you so much for that opportunity to follow up on that question. So from a research point of view, I'll say this is definitely a priority for us. One of the knowledge mobilization hubs that we have funded as I mentioned, in August 2023, is from a group at the University of Calgary that are focused on Inuit Perinatal Health Hub, which is really about developing and building Inuit-specific resources and support for Inuit women in Nunavut. And so I think that's just an example of a very particular community and mobilizing research evidence that is focused on perinatal health. I'll also just add quickly that on March 9th of 2022, a ministerial roundtable was held with some key stakeholder groups in perinatal mental health, which included experts, practitioners, people with lived and living experience, that's focused on examining access to perinatal mental health. And we're looking forward to seeing the results of that study. I think my colleague Cindy had also mentioned about the work focused on creating a national clinical practice guideline for perinatal mental health. I'll be happy to follow up with you with additional details from that research and what we're learning. Thank you.
Thank you. I wonder, Ms. Wong or Ms. Hurley, whether you'd have anything else to add in terms of more sort of on the ground support for access to care.
I'll just close the loop in terms of the mental health promotion that we do with the Public Health Agency of Canada. Our programs are not specifically aimed at perinatal mental health, but more at addressing risk factors and boosting protective factors. We do have one project that's funded right now that's looking at maternal mental health through a wraparound model, and that's just an example among more general programming. I'll turn to my colleague, Mark, who works more with the Division of Children and Youth.
Yes, thank you. So we do offer the Canada Prenatal Nutrition Program, which is a $26 million annual program to community-based groups. And through those community-based groups, we look to develop and deliver comprehensive, culturally appropriate programs that promote health, including mental health. An example would be a program called Nobody's Perfect Program, where trained facilitators work with participants to increase their understanding of health behaviors and also to bring them in contact with community resources and services, including mental health.
Thank you. Madame Laroche pour 2 minutes et demie, s'il vous plaît.
Merci, Monsieur le Président. Donc, Monsieur Morgan, j'aimerais revenir.
Thank you, Mr. Chairman. Mr. Morgan, I'd like to come back to you on the study that you've done on comparative with other countries. So I was wondering if you had anything to add to my previous question.
As the regulator, we work with our international partners on these issues regularly. So, oh oui, oh.
Désolée, est-ce qu'on peut arrêter? Il y a eu un problème d'interprétation pendant quelques instants, Monsieur le Président, si on peut.
I think that there was a little bit of a delay on the interpretation there, so if we could just begin your answer again, please.
Oui, non, parfait, et peut-être je peux parler en français. Donc vraiment.
So we work very closely with our international partners on these issues. For example, we're working with an organization which is known as ITH, which goes towards working the harmonization of our rules and regulations and our guidelines on clinical trials. But we're working at other tables as well. There's also one called IGMA, which is an international organization of health regulators. Now, they're looking more closely at the specific data, and we're trying to see how we might be able to improve our process, our methodology of obtaining data from major corporations, as it were. So we're working in close collaboration with our partners internationally. Well, contrary to other countries, I think in Canada it has a unique situation that it's a joint jurisdiction, and sharing of data between provinces and the federal government is relatively difficult. In Quebec, it works quite well. Much of the research is funded by the federal government. So how do we compare with other countries' strategies? Because here we do have joint responsibility for health and health data. Yes, quite correct. But a more general answer, if you will, perhaps Cindy would be better placed to answer that question. But on the issue of clinical trial data, for example, it's not really a specific jurisdictional issue. We're dealing here with corporate sources of data. So, but that my answer referred to data in general. Ms. Moriarty? Well, in general, I can say that we do share data wherever, whenever, and wherever they are available. This, of course, contributes to the collection of data, the application of these data, and we work with various other sources as well. Thank you, Madame Laroche.
Welcome to the committee. You have the floor for the next 2.5 minutes.
Thank you, Chair. And I'd like to thank the witnesses for their important testimony. I'd like to ask one question for all three witnesses to answer. My question will be related to the calls for justice. As you'll remember, the Missing and Murdered Indigenous Women and Girls Commission was started in 2016, and three years later, their final report was published. There were 2,038 participants that engaged in this important work of the commission. Unfortunately, out of the 231 calls for justice, only 6 of the 7 are being implemented. Could each of you explain why the federal government has failed to meaningfully address these calls for justice to date? Chair.
Thank you for the question. I can't speak on behalf of all departments. I can share a little bit about what is happening at Health Canada. We have a program that provides funding that is directed at addressing anti-Indigenous racism, making changes in the health system, and sort of providing funding for various projects through that to make systemic change. We're certainly looking within the department at everything that we're doing with that context in mind. And we also contributed recently to the study that was done on forced and coerced sterilization, which has targeted largely, but not exclusively, Indigenous women. So it's something that we're looking at with great attention. I'll refer to my other colleagues from Public Health Agency and CIHR if there's anything else you want to add.
Hurley, please.
Yes, I'd be pleased to add, from the point of view of the Public Health Agency of Canada, addressing the calls for justice is a multi-sector, all-of-government responsibility, and we are contributing from a health perspective. I've mentioned some of the programming that we do to address family violence and gender-based violence, and that includes projects that are specifically supporting the needs of Indigenous women and girls, Indigenous communities. Our department also works with Indigenous partners on data collection so that we can better understand what family violence, including child maltreatment, looks like for all populations and including Indigenous populations. That's part of our contribution. And
thank you, Ms. Hurley and Ms. Idlout. Next, Ms. Vecchio, please, for 5 minutes.
Thank you very much, and thanks for having me back on this. I would like to move and talk about eating disorders. I know that when we're looking at mental health and wellness, eating disorders was something that was very prominent with young women. What are we doing through education and awareness programs to encourage young women to understand healthy eating?
Annie, is that something you can take?
Ms. Hurley?
Thank you. I can say from the point of view of Public Health Agency of Canada, as I've mentioned, we work in programming to promote mental health and prevent mental illness, and so that's addressing risk and protective factors across a range of areas. We are currently supporting 2 projects that I can think of in particular. That one is working to create a peer support network for people with eating disorders. One is working on addressing weight-related bullying and unhealthy body images. So those are some examples of how that programming can address that issue. Others may have other comments.
I know I have questions on a variety of different things, so I'm Sorry. Someone had also, and I believe Mr. Garrison had talked about dosages when it came to medications. That's something that I've always found really strange. When my son, who is a 20-year-old, 6'2" man, and his 52-year-old mom are taking the exact same dose of a medication. Can you give me some ideas on what we're doing to ensure that or what studies have been done, or when we're expecting studies to come out indicating what the dosage properly should be based on gender?
I can jump in just quickly if it works. So one of the things that we're doing right now is we're actually moving regulation. So we've just gone to Canada Gazette Part 1 to ask companies or people basically bringing forward submissions for disaggregated data. So whatever data they have that they may have provided to other jurisdictions, we want them to provide to us. So that's one step. Again, it's gone to CG1. I think that stakeholders were quite happy with it. We're hoping to move that forward in the next year or so to finalize. And then a second step that we're actually taking is part of our clinical trials reform. And so we're taking a look at the whole regulatory structure of clinical trials. And one of the things that we want to ask companies to do is to provide us with a diversity plan. And so we've gone out, and my colleagues have consulted on it right now. It seems to have been received favorably. And so that would actually require providers to disaggregate, basically, and to try and provide us with disaggregated data.
Thanks so much. That, to me, is just so important. When I look at it and I think, we're so different. How are we taking the same medication? It just doesn't make any sense to me. So I really appreciate that. Back to fetal alcohol, or back to a different public awareness and fetal alcohol syndrome. We know that just a drop of alcohol can cause problems, especially in the first few weeks of pregnancy. What are we doing to ensure that Canadian women are aware that they could be at risk of fetal alcohol syndrome for the child? What are we doing for prevention there?
Hi, thank you for the question. So the FASD National Strategic Projects Fund funds $1.5 million annually to collaborate with key stakeholders and partners across Canada to develop nationally applicable tools, resources, and knowledge that can be used to prevent FASD and improve outcomes for those who are already affected, including families and communities. And also through the program, which I mentioned earlier, the Canada Prenatal Nutrition Program and the Community Action Program for Children, we provide information and guides and facilitators to share information with pregnant people about the risks of alcohol and substance use in general during pregnancy.
Thanks very much. Do I have 1 minute left? Getting in a little bit more of a dicier area, but when we talk about safe supply, I look at safe supply and I look at women using the safe supply and the environment of where the safe supply is being used, which then becomes extremely unsafe for women. Any comments on that when it comes to safe supply and safety of women that could lead to violence?
From a safe supply point of view, thank you for the question. I'm sorry we don't have anyone here that's got the expertise in substance use and addiction. My understanding is there's a separate study that's underway or going to be underway. In terms of your link to violence, I don't know if my public health agency colleagues have something to say.
I will only add that I don't know the details about safe supply, but certainly substance use and its links to violence, and as an outcome of having experienced violence, are really interconnected issues. So a lot of the work that we fund and support is addressing both of those issues together. For example, supporting mothers who've experienced abuse and substance use, just as an example.
Thank you. Ms. Atwin, please, for 5 minutes.
Thank you, Mr. Chair. We've really kind of covered the gamut here of a lot of different topics. So I'm so appreciative to our witnesses for their wealth of knowledge. Ms. Clifford, in your opening, you mentioned that there's kind of been a marked shift over the last decade or so as far as a renewed focus on women's health and women's health research in particular. Can you expand on that? What do you account for in this shift? I mean, certainly government support is one piece, but I'd really love to highlight the different voices, women's voices and advocacy that has created this very important shift.
Great. Thank you for the question. And how long do you have? No, first of all, I have to credit so many people, including Dr. Kaida, who is here today, as our current scientific director of the CIHR Institute for Gender and Health. Dr. Kaida joined us within the past year or so, and before her, it was Dr. Kara Tenenbaum who held the tenure of that institute for 8 years. And I would say, again, you know, it's through a combination of efforts that CIHR recognized early on the importance of encouraging the research community to pay attention to the importance of studying sex and gender in their research projects. It probably won't come as a surprise to you that initially what we did was simply put a tick box on an application saying, did you consider this, yes or no? It didn't take us long to figure out that that was actually inadequate because you can just tick a box. That doesn't mean you did it or you did it well. So over the years, what we have done is little by little ensure that those who apply for our funding and those who are peer reviewing funding must take training modules to make sure that they're aware of this. And then when the actual research protocols are reviewed, there is a discussion about this. So the entire academic research community is much more aware of these issues. And I do have to say it's thanks to champions like Dr. Tenenbaum, like Dr. Kaida, and others who ensure that this topic remains front of mind for all of us who are doing this work. Thank you for the question.
Thank you very much. And Ms. Moriarty, you know, I can't help but think about how it's, you know, there's so many women in particular who are nurses or nurse practitioners, of course, physicians as well, but where it's very, I think, female dominated in certain sectors. And I also think about how we're seeing a lot of burnout. And so I'm wondering, you know, if you can provide us with some direction or some advice, and how can we better care for those that take care of us?
Thank you for that question. I wish I had an easy answer for you. I mean, COVID, the pandemic really did a number, I think, on everyone. I think the system was, I'm not saying anything you don't know, the system was so stretched. And then I think the pandemic just put so many of at the individual level and the system level, just kind of put everything over an edge. So I don't have easy answers for you. You know, we are working to provide mental health support. The mental health supports that my colleague Suki Wong talked about are available to practitioners just as much as they are to patients. And I think there's other work that's going on between the department and provincial territorial governments to look at this crisis in terms of the HA Health Human Resources. But I don't have a specific solution for you. I'm sorry.
Would anyone else like to add to that?
I could add. Hi. Yes, from the point of view of, again, the mental health promotion work at the Public Health Agency of Canada, we are administering some funding that was provided in Budget 2021 to address the mental health impacts of the pandemic, and that included funding to address PTSD and trauma in service providers, including healthcare workers as well as public safety personnel and other people who were on the front lines during the pandemic. So those projects are doing things like peer support, training for resiliency, trauma-informed practice, reducing stigma, and we do hope that they'll have a lasting impact. They'll leave a legacy of some knowledge and resources that will help address some of those issues.
Thank you very much. And just with my remaining time, Dr. Kaida, you mentioned health hubs. I think you mentioned 5 would be across the country. And as a proud Atlantic Canadian, I'm wondering, is there one in the Atlantic region, and what can we expect as far as you know, projects or initiatives that will be undertaken?
Thank you so much for this question. There are 10 health hubs across the country. There isn't one specifically located in your province. However, what was very critical for us as the funders is to ensure that whoever was funded had national networks across the country. So perhaps these are virtual hubs. They're not bricks and mortar. They're virtual hubs. But perhaps the PI or the principal investigator is not located in your province, but there will be researchers, people with lived and living experience, community advocates, leaders, etc., who are based in your province. I'm happy to provide the specific details of the folks who are involved. But certainly that has been a priority for us as an initiative, making the most of the fact that we have obviously we've got diverse priorities over the provinces, but we have expertise from coast to coast to coast.
Thank you, Dr. Kaida. Next, Ms. Roberts, please, for 5 minutes.
Thank you, Mr. Chair. I guess my question is, 75% of, and I think I'm going to address this to Mark, 75% of women in Toronto have experienced violence on our transit systems. Now, when they get arrested, I know we provide education when they go to jail. What is the percentage of women receiving that same type of attention as opposed to the men?
I don't have those numbers available to me at this point. That's something I would have to bring back.
Okay, that would be great. Because I guess my question is, you know, women are being attacked more than men, let's be honest. And, you know, it's important from a mental health issue that we provide them with the proper mental health care that they require. I personally, my previous life, I was a branch manager, robbed 5 times and shot at once. And, you know, I appreciated the counseling. I'm blessed that I guess I have a thick skin. I don't know, maybe that's the Italian in me. But it's important that we address that, because I always find when I talk to constituents that, you know, I've spoken to a few women and they said, well, you know, when you report it and when it comes out, it's like, well, what did you do to provoke it? What were you wearing? What were you doing? And that's an issue that I think we have to get our heads around. And women are women, men are men. So we provide them the tools that they need while they're incarcerated to make sure they don't go out and offend. But what guarantees do we have for the women that have been offended, and how can we protect them better?
Yeah, so my corrections background seems to be calling me back a little bit here, but I would like to give the opportunity to any of my colleagues on this panel who have more of an expertise in violence and mental health.
Hurley?
I can just really confirm how important it is, as you say, that the people providing services and supports to people who've experienced violence understand how violence can affect people. So that's being trauma informed. So not asking, what did you do? What were you wearing?
That's
Why
right.
do you let him do that to you? So some of the work that we're doing is, in fact, aiming to educate and equip service providers. That's healthcare workers, social service providers, but others too, teachers, coaches. In fact, all of us should be trauma informed, and we shouldn't need to know, were you shot at? I'm so sorry to hear that happen. We shouldn't need to know. We should use safe approaches with everyone, and that's part of the work that we're doing to educate, not just to stop the violence, but also to make sure that people are getting appropriate care from service providers. So it's a really good point you raise.
2 minutes. So I guess, you know, we continuously talk about the fact that, you know, women are more susceptible to violence than men. And it is our responsibility to make sure that we educate our children, especially our male children, on the respect for women. And I know, being part of the Status of Women Committee, that is something that we definitely spoke about. We recently had the gymnastics review where the CEO, I questioned him personally, and he said that there was over 600 women that reported violence and nothing was done. When I asked him if he had his children, if they were in the same situation and they came home and said, this is what happened to me, would you have launched an investigation? And his response was yes. So how, you know, we have to make sure that men understand women are just as important, and we need to provide that service to them so that they can move on with their life. Because sometimes if you don't, it sets them back, and some don't recover. So I think we have to, as you know, parliamentarians, make sure that people understand the importance of mental health on violence against women. Would you agree?
Absolutely. It's so fundamental. Experiencing violence, particularly in a relationship, if it's with your spouse or your dating partner or your parent, where it can be repeated or ongoing, that can have, the more it goes on, the longer lasting the impact can be on physical health and certainly on mental health. So absolutely, to be able to go on and have healthy relationships later in life, we need to be able to prevent the violence and also to support those who've been affected by it.
I'm not sure if you know Bill S-205 that we're working on right now. One of the senators who lost daughters to the same situation, and hopefully we can make a difference in this parliament to ensure that that never happens again with the electric monitoring system, because it's a tragedy. that we have no opportunity to protect the women that we should be protecting.
Thank you, Ms. Roberts. Next, Ms. Sido, please, for 5 minutes.
Thank you, Mr. Chair. My question is about ovarian cancer. We know early detection is the key, and if we detect early, survival rate is high. I want to talk about, I know my colleagues already talked about the ovarian cancer. Ovarian cancer is the 5th leading cause of cancer-related deaths in Western world. 1 in 4 women on the first line treatment chemotherapy, they don't respond. So my question is that what measure is being taken on the research side so the treatment line or the research can be, we can find some kind of treatment who can respond to the ovarian cancer, or what research can be done? And other question is related to that. In 10 women health hubs, also we are giving education awareness in those hubs. These 2 questions I have for that. Who's related? The first, I think, Dr. Clifford, you can respond.
So maybe I'll start off and then I'll turn it over to Dr. Kaida. And I agree with you that those statistics around 1 in 4 women not responding to that first-line treatment certainly underscores the importance of us finding other treatments there. I don't have it handy right now, but I will go back and take a look at what we have funded in this domain to see whether there may be some early studies that are showing some promising treatments, and maybe what will go on after that. So that's on me to follow up and ensure I'm providing you and the committee with that information. But maybe Dr. Kaida, specifically around the hubs, I think the question was, that one's for you.
Perfect. Thank you, Dr. Clifford, and thank you for that question. So absolutely. So I think your question is education and knowledge exchange an important component of the hubs in terms of an objective. And it is actually an explicit objective of the funded hubs. So I'm really, the idea and the need for the hubs really speaks to the fact that sometimes we have research evidence and we have scientific findings, but those findings are not being mobilized or translated to the communities, the patients, the families, the individuals who need that information and can use that information to act to improve their own health. And so one of the first objectives of these hubs specifically is to, I'll just read it so it's accurate, mobilize and scale up newly generated and existing knowledge and models of care. So the audiences for that knowledge include patients, include providers, include policymakers, and include the general public who deserves to know of what we're finding from our scientific research in women's health.
Thank you, Dr. Kaida. My next question is for PHAC. Women with the diabetes in pregnancy continue to have poor pregnancy outcomes compared to women who don't have diabetes. What efforts are being taken to respond to this through the National Framework for Diabetes? And what are the efforts to collect data on gestational diabetes, which are impacting on women?
Thank you for your questions. And I also want to thank you for your bill that led us to the development of the diabetes framework in Canada. So one of the things specifically for data, we have some systems that we collect information. I don't have the information about gestational diabetes, so I will have to get back to you and the committee on that. With regards to pregnant women, you may be aware that last year the Public Health Agency launched a Type 2 Diabetes Challenge in collaboration with the Privy Council Office. And one of the projects of the semi-finalists is specifically an Indigenous project that is addressing a young mother. It's called 39 Moons. It's an Indigenous project that really will focus specifically on young mothers and educating them about healthy eating, healthy behaviors to help prevent diabetes for these women, but also their children.
Thank you. And Mr. Chair, do you have more time? Okay. So my last question is, we know that the virtual and remote care is one of the many important tools that assist patients. what perspective can you give us on using virtual and remote healthcare when it comes to women's health? Anyone can answer that.
I guess maybe I'll take the question. Thank you for that question. I think that the women-facing access, need for access, is especially acute in remote areas as well. So thank you for that question. One of the tools that we have to help women in remote areas would be the Wellness Together Canada tool, where we do have 24/7 access to not just counseling, but also to for step care, right, for self-assessment and for peer discussions as well.
Thank you very much, Ms. Sidhu. Suite, Madame Larouche pour 2 minutes et demie.
Madame LaRouche, 2 minutes and a half. Thank you, Chair. My next question could be either for Ms. Moriarty or Lee. I was with the Status of Women, and we've done a study in 2023 on the mental health of Indigenous women and girls. So that same question did arise. We had a witness from a women's shelter and who testified before us that there was, in fact, opportunities for some of these shelters to provide mental health. And in Quebec, it's financed by the Department of Health or the Ministry, and it's a matter of financial resources, of course, for some projects. In order to provide and work in the field of mental health, funding of these has to be made available either by the province or the federal government. How can we improve and increase transfers of financial resources to provinces such as Quebec, but all provinces? Well, thank you for the question. I think you asked me the question, but I believe that my colleague would be better placed to answer the question. So, please.
I know you know well that the delivery of mental health services is a shared jurisdiction, and I note the action plan that the province of Quebec put together with respect to the pillars to address mental health. So we're working very closely with our colleagues in the province of Quebec to look at how the services can be delivered in a way that's targeted to the needs of the jurisdiction.
Merci beaucoup. Last round of questions for this panel will come from Ms. Idlout for the next 5 minutes, please. 2.5 minutes.
Oh, I was going to ask much more questions if I had that 5 minutes. My questions will go to the Department of Health. We all know that my riding is a huge riding. My riding has 3 time zones, 25 communities. I know that for medical appointments, because of the lack of available doctors and nurses, the reliance on medical travel is huge. For example, the government of Nunavut in 2019 reported that they expected to spend $92 million just for medical travel. So all these expenses probably would have ended up in the pockets of airlines, hotels in the south, and meals being covered in the south. I wonder if the department can share with me what investments they have for medical care to be provided in Nunavut, how many doctors, how many nurses will increase rather than having to spend medical patients outside of our riding.
Thank you for the question. I think, unfortunately, that question would be better directed to Indigenous Services Canada, who manage much of this. So we can take that back if that would be helpful. And other than that, all I can offer is that, through the bilateral agreements, including with Nunavut, investments will be made. My understanding is those are still being negotiated, and that hasn't been finalized yet.
Oyanamik, does the department have data on how many doctors and nurses are in Nunavut that are full-time that remain in Nunavut?
I don't have that information offhand, no. I understand it's a challenge. I truly do. I just don't have the data handy.
Could you make that available to this committee once you get it?
Yes, we can do that. We'll have to follow up with Indigenous Services Canada as well.
Thank you so much. I also understand that in January 2021, the federal government announced ongoing consultations with Indigenous partners and the provinces and territories to co-develop distinctions-based Indigenous health legislation. However, the government has yet to table this legislation. Can you confirm when the federal government plans to table this distinctions-based Indigenous health legislation?
Thank you for the question. I'm not in a position to give you a specific time frame on that at this time. I'm sorry.
Thank you, Ms. Idlout. That's your time, and that's all the time we have for questions. Just a reminder to members of the committee that today is the deadline for any supplementary or dissenting reports on medical devices. So I presume that if there are going to be any dissenting or supplemental reports, they're well underway and mostly translated by now. To all of our panelists, thank you so much for being here with us today. This was an excellent briefing. It's not often that you have a large collection of officials and every one of them has their expertise to contribute and gets a chance to contribute. So it was very comprehensive, and certainly appreciate your professionalism and patience in the way you've handled all the questions. Ms. Moriarty, I hope you're feeling better. Good on you for plowing through the COVID fog and in this panel. We greatly appreciate it.
You're very welcome. The transcripts will speak for themselves, but I thank you all for your patience as well.
Is the will of the committee to adjourn the meeting? Yes, sir. We're adjourned. Thank you.